So today we'll go through the article Clinical Characteristics and Outcome in 15 Dogs Treated with Transsphenoidal Hypophysectomy for Non-Functional Sellar Masses. This is out of VetSearch from 2023. It is open source, so we will get started and the software will read it to us.
Clinical Characteristics and Outcome in 15 Dogs Treated with Transsphenoidal Hypophysectomy for Non-Functional Sellar Masses. Abstract. Objective, to characterize the clinical features, neurological examination findings, diagnostic imaging results, histopathological findings, and outcome following transsphenoidal hypophysectomy in dogs with non-functional sellar masses. Study design, multi-institutional retrospective study. Methods, medical records of dogs that underwent TSH for NFSM were reviewed for clinical signs, physical and neurological examination findings, diagnostic imaging results, endocrine testing, surgery reports, and outcome. Magnetic resonance imaging was re-reviewed, and tumors were classified using the previously described system according to pituitary tumor extension and vascular involvement. Owners of dogs that survived a discharge were contacted. Results: the majority of dogs presented fermentation change. The mean pituitary to brain ratio was 1.05. 8 dogs had a tumor imaging classification of 5B. 11 dogs were diagnosed with a non-functional pituitary adenoma. Perioperative mortality was 33%. The median survival for all dogs was 232 days. When dogs that did not survive to discharge were excluded, the median survival time was 708 days. 7 of 10 dogs that survived the perioperative period received adjunctive therapy. Owner assessment of outcome was excellent to good. Conclusion: the common presenting complaint for dogs with large NFSM causing mass effect was mentation changes. Dogs with NFPA that survived a discharge and received adjunctive therapy had good to excellent outcomes. Clinical significance: transsphenoidal debulking with adjunctive therapy can be considered for the treatment of NFSM causing clinical signs of mass effect in dogs. Successful long-term outcomes are possible. 1. Introduction. In humans, sellar masses are typically benign tumors often detected due to symptoms of mass effect, endocrine symptoms, or identified incidentally. Bioimaging studies non-functional sellar masses are tumors that do not secrete a sufficient concentration of hormone for detection in the blood or result in endocrine symptoms as a consequence of hormonal inactivity. Patients typically present with large tumors that cause neurological symptoms of mass effect such as headache, vision loss, or hypopituitarism. Surgical resection in humans remains the treatment of choice for non-functional pituitary adenoma. Exert. Insignificant mass effect surgery is infrequently chloride due to supra- or parasellar extension. Adjunctive radiotherapy is typically reserved for more aggressive and recurrent tumor types based on immunohistochemistry and transcription factor assessment. Transsphenoidal hypophysectomy is an effective therapy for the treatment of functional pituitary adenomas, resulting in pituitary-dependent hypercortisolism in dogs and hypersomatotropism in cats. Transsphenoidal surgical removal of functional pituitary tumors in dogs and cats can be performed by experienced surgeons with low morbidity and mortality. Pituitary adenoma is the most common tumor of the pituitary fossa in dogs, but other sellar masses can occur, including meningioma, craniopharyngioma, ependymoma, germ cell tumors, and metastatic neoplasms. NFSM become clinically significant when they cause compression of the hypothalamus and surrounding brain structures. TSH is less commonly performed for NFSM, producing clinical signs due to mass effect. Treatment options are limited. Once sellar masses are large enough to result in neurological signs, the ratio between the height of the pituitary gland and the area of the brain is known as the pituitary to brain ratio. This is an objective measurement that was developed by Kuster et al. To differentiate enlarged from non-enlarged pituitaries in dogs. NFSM in dogs tend to have a high PB ratio due to clinical presentation later in the disease course. The PB ratio is an important preoperative prognosticator in dogs, with survival time and disease-free fractions decreasing with increasing pituitary tumor size. This information may make clinicians apprehensive about recommending surgery for dogs that have large NFSM, although Mamalak et al. Show that large pituitary tumors could be successfully removed. In contrast to functional pituitary adenomas, little is known about the clinical presentation and outcome of dogs with NFSM following TSH. To the author's knowledge, this is the first report on the outcome in dogs that have undergone TSH for NFSM. The objectives of this study were to characterize the clinical features, neurological examination findings, diagnostic imaging results, histopathological findings, and outcomes following TSH in dogs with NFSM, and assess the outcome and quality of life of dogs that survived a discharge via owner interviews. Based on our clinical impression, we hypothesize that dogs with NFSM can undergo TSH successfully and have resolution or improvement of presenting clinical signs. Materials and methods. Case identification. Medical records from 2 institutions were searched for dogs that underwent TSH between January 1, 2009 through December 31, 2020. Inclusion criteria included dogs that were diagnosed with NFSM and had undergone TSH. Dogs were considered to have NFSM if they presented with clinical signs of mass effect and the mass was a pituitary adenoma that did not secrete a sufficient concentration of hormone for detection in the blood via biochemistry or endocrine testing, result in clinical manifestations of hypercortisolism, or it was of non-pituitary origin based on histopathology. Dogs that had undergone TSH for a functional pituitary tumor were excluded from the study. Information obtained from medical records included signalment, body weight, historical findings, clinical signs, diagnostic test results, PB ratio, pre- and post-operative, neurological examination findings, length of anesthesia, length of surgery, intraoperative appearance of the tumor, intraoperative hemorrhage, ease of tumor removal, intraoperative complications, length of hospitalization, development and duration of central diabetes insipidus, post-operative complications, histopathological diagnosis, immunohistochemistry results, outcome, survival, and adjunctive therapies. Brain magnetic resonance images were acquired with a 1.0 Tesla magnetic resonance imaging system. MR imaging was reviewed for each dog to determine the Tumor imaging classification based on the MR imaging 5-point classification system for canine hyperadrenic corticism according to pituitary tumor extension in dorsal and craniocaudal directions developed by Soto et al. Using this system, tumors were further classified as type A, indicating there was no circle of Willis or cavernous sinus involvement, or type B, where these blood vessels were involved. 2.2. Surgery and postoperative therapy. TSH was performed using a modification of a transoral transsphenoidal approach. Previously described localization of the sellar was performed by drilling pilot holes in the basis sphenoid bone followed by CT, and surgery was performed using a high-definition video telescope. At induction of anesthesia, hydrocortisone or methylprednisolone and ampicillin sodium/sulbactam sodium were administered. After surgery, all dogs recovered in an intensive care unit. Postoperative hormone replacement therapy consisted of hydrocortisone and desmopressin. Desmopressin was administered for CDI and was either gradually decreased until the drug could be discontinued or continued in dogs that remained polyuric due to persistence of CDI. When each dog was able to eat and drink, oral hormone replacement therapy was started and continued lifelong. Cortisone acetate or prednisone and thyroxine. Postoperative care and monitoring was patient-dependent, but typically vital signs, serum electrolyte concentrations, central venous pressure, fluid input, urine output, urine-specific gravity, and body weight were measured every 2 to 4 hours postoperatively. These parameters guided the administration of IV fluids. Depending on recovery and response to therapy, these parameters were typically monitored every 6 to 24 hours. Other postoperative medications included ampicillin/sulbactam, fentanyl continuous rate infusion, mirapitant, and pantoprazole. Neurological status was monitored at least every 12 hours through serial neurological examinations, specifically evaluating mentation, pupil size, pupillary light reflex, blood pressure, and heart rate for indications of increased intracranial pressure. Serum electrolytes, thyroid function, and urine-specific gravity were recommended to be repeated at 1, 3, 6, 9, and 12 months after surgery, and then yearly. Hormone replacement therapy was modified based on these test results. Postoperative brain MR imaging was recommended to be repeated at 3, 6, 9, and 12 months after surgery, and then yearly. 2.3. Outcome, survival, and follow-up. Survival time was defined as the number of days from surgery until death or last contact. Medical records were reviewed until date of death or time of last veterinary visit. Surgical mortality rate was determined by death of any cause within 4 weeks of surgery. The outcome for dogs surviving to discharge was determined by owner response to 2 questions provided by email and/or telephone. The first question: how would you describe the improvement in clinical signs your pet experienced after surgery, with excellent being complete resolution of clinical signs, good being some resolution in clinical signs that resulted in an improved quality of life, and poor being no resolution or worsening of clinical signs following surgery. The second question: would you make the same decision again and elect surgery for your pet? 2.4. Statistical analysis. Descriptive statistics are reported and were composed according to standard protocol. Parametric data are reported as mean plus or minus standard deviation, whereas non-parametric data are reported as median. Data range is provided where clinically relevant. Continuous variables were assessed for normality by visual inspection of histogram plots and by using the Shapiro-Wilk normality test. Equality of variances was checked with Levine's test. Non-Gaussian data were analyzed using non-parametric methods, specifically Spearman's rho for correlation of non-parametric data. Kaplan-Meier survival curve was used for survival outcome analysis. Missing data were handled with case-wise exclusion. Owner responses were not statistically analyzed and are reported as qualitative data. A p-value 0.05 was considered significant. All analyses were conducted using commercial software. 3. Results. 3.1. Study population and signalment. 46 dogs underwent TSH for a sellar mass between March 2009 and March 2020. 31 dogs were excluded for having a functional pituitary tumor, leaving 15 dogs for inclusion in the present study. Represented breeds included English Bulldog, Staffordshire Terrier, mixed breed dogs, and one each of the following breeds: Labrador Retriever, Miniature Dachshund, American Bulldog, Portuguese Water Dog, Chow Chow, Boxer, Boston Terrier, and Yorkshire Terrier. The mean age at time of surgery was 8.4 years and mean weight was 22.5 kilograms. 3.2. Clinical signs at presentation. Clinical signs at presentation included mentation change, decreased appetite or anorexia, weight loss, lethargy, ataxia, and visual changes including blindness. Less common clinical signs at presentation included circling, pacing, tremors, neck or head pain, sleeping more, cranial nerve 7 deficits, and weight gain. All dogs presented with at least one clinical sign of mass effect. 2 dogs that presented 4 clinical signs of mass effect also had signs resembling an endocrinopathy. 1 dog had biliuria and polydipsia, which began after starting prednisone therapy. This dog was diagnosed with a craniopharyngioma. The other dog had a history of diffuse hair loss and weight gain but presented for anorexia and cervical pain. The dog was diagnosed with hypothyroidism, suspected to be lymphocytic thyroiditis, based on a low thyroxine concentration. This dog had PUPD at the time of surgery, but this started after prednisone therapy was initiated for clinical signs of mass effect. Serum biochemistry was unremarkable before prednisone therapy and an abdominal US revealed a normal liver and adrenal glands. No endocrine testing was performed prior to starting prednisone. This dog was diagnosed with a corticotroph pituitary adenoma. 3.3. Preoperative data. All dogs underwent MR imaging of the brain. The PB ratio was calculated prior to TSH. The mean PB ratio was 1.05. All dogs had enlarged pituitary glands. No correlation was found between survival and PB ratio. 13 MR images were available and evaluated using the previously described classification size. 10 all 13 tumors had circle of Willis or cavernous sinus involvement, classifying the tumors as type B tumors were classified as 3B, indicating tumor extension beyond the dorsum celli up to the third ventricle and contact with the optic chiasm and or mammillary body but not the interthalamic adhesion. 4B indicating tumor extension beyond the dorsum celli and contact with the optic chiasm, mammillary body, and interthalamic adhesion, and 5B indicating tumor occupation of the third ventricle. Tumor classification of dogs that died during the postoperative period were 3B, 4B, and 5B. Dogs that survived to discharge had tumors classified as 3B, 4B, and 5B. No standardized endocrine testing was performed. All dogs presented to a veterinarian for clinical signs of mass effect and not hypercortisolism. 3.4. Intraoperative data. The mean surgery time was 168 minutes. The mean anesthesia time was 318 minutes. Surgery reports were available for 14 cases and findings are reported in Table 1. Gross tumor was left behind due to hemorrhage. Tumor consistency being too firm. Goal of debulking versus complete removal, or was not reported. For adenomas, the consistency was soft, firm, combination, or not described. Hemorrhage was minimal, moderate, significant, or not reported. Ease of tumor removal was difficult, easy, or not reported. For other tumor types, the consistency was soft or combination. Hemorrhage was minimal or moderate and persistent. Ease of tumor removal was easy or not reported. 3.5. Postoperative outcomes. 5 dogs died or were euthanized during hospitalization. 1 of the 5 dogs did not recover from anesthesia and was euthanized prior to extubation. The other 4 dogs recovered and died or were euthanized within 4 days. Post-surgery, the mentation of the 4 dogs that recovered was inappropriate, bright and alert or not described. All dogs that recovered from surgery received desmopressin. All dogs that recovered from surgery but died before discharge were on desmopressin until time of death. In 10 dogs that survived to discharge, duration of CDI was based on desmopressin administration. Desmopressin was continued long-term, which was until death or last contact when alive or was discontinued within 6 months of surgery. The most common postoperative complication was superficial corneal ulceration. Other complications included moist interdigital dermatitis which resolved, besamethasol which required surgical intervention, mucopurulent nasal discharge, and respiratory difficulties due to facial swelling, which resolved after several days of warm compression. No complications related to the surgical site or incision were reported. The median length of hospitalization was 3 days. When dogs that did not survive to discharge were excluded, the median length of hospitalization was 3.5 days. 3.6. Histopathology. Tumor types diagnosed via histopathology included pituitary adenoma, meningioma, ependymoma, craniopharyngioma, and primary intracranial primitive neuroectodermal tumor. Pituitary adenomas were classified as a chromophobe pituitary adenoma and pars intermedia pituitary adenoma. Immunohistochemistry was performed on the remaining samples and further classified the tumor type as corticotroph pituitary adenoma, melanotroph pituitary adenoma, somatotroph pituitary adenoma, or pluriformo, now pituitary adenoma and growth hormone expression. Tumor types of dogs that did not survive to discharge were pituitary adenoma, ependymoma, craniopharyngioma, and primary intracranial primitive neuroectodermal tumor. 3.7. Long-term outcome. All dogs that survived to discharge were alive for at least 125 days post-surgery. The 1, 2, and 3-year survival rates of 10 dogs undergoing TSH for NFSM that survived to discharge were 70%, 50%, and 40%, respectively. Median survival time for all 15 dogs was 232 days. The longest surviving dog at the time of manuscript drafting had a pituitary adenoma and was alive at 1658 days. When dogs that did not survive to discharge were excluded, the median survival time for the 10 dogs was 708 days. Our study was underpowered to determine whether tumor type was related to survival for dogs with adenomas versus all other tumor types. Median survival time for the dogs with adenoma and the dog with meningioma was 517 days and median survival time for dogs with other tumor types was 1 day. Dogs that were diagnosed with tumor types other than adenoma or meningioma did not survive to discharge. Median survival time for dogs that did not receive adjunctive therapy was 232 days and median survival for dogs that did receive adjunctive therapy was 708 days. Despite the clinical impression that all dogs that survived to discharge had improvement in neurological status and systemic health, the timing and degree of resolution of presenting clinical signs could not be determined due to the retrospective nature of this study. Owners of the 10 surviving dogs were contacted via telephone or email. 7 owners responded to the 2 questions. Outcomes were reported as excellent and good. All 7 owners stated that if given the choice, they would again elect surgery for their pet. 3.8. Adjunctive therapy. 7 of 10 dogs received adjunctive therapy, including radiation therapy, chemotherapy, and long-acting somatostatin analog. All dogs receiving adjunctive therapy had an incompletely excised pituitary adenoma. 3 dogs underwent RT 1 month post-TSH due to known incomplete tumor resection. Protocols were at the discretion of the providing radiation oncologist and included a planned protocol of 60 GI with inadvertent administration of 80 GI fractionated radiotherapy, 54 GI FRT, and 33 GI stereotactic radiotherapy. 1 dog underwent RT approximately 13 months post-TSH after developing clinical signs of mass effect and MR imaging confirmed regrowth. This dog underwent 8 of 17 planned FRT, receiving 19 GI, but died during RT after experiencing a ruptured splenic hemangiosarcoma. 1 dog had a second TSH performed 10 months after the initial TSH, due to clinical signs of mass effect and regrowth confirmed by MR imaging. Clinical signs recurred 2 years after the second TSH and the dog received 5 doses of dacarbazine. The pituitary mass was however static at this time based on MR imaging. 2 dogs were enrolled in a clinical trial and received pasireotide. 3.9. Postoperative imaging, tumor, regrowth, and clinical signs of mass effect post-TSH. Despite the recommendation for postoperative imaging at set time points, this was inconsistently followed. Postoperative imaging was performed at least once in the 10 dogs that survived to discharge. By comparing multiple postoperative imaging studies, 1 dog had tumor Regrowth. One dog that underwent TSH twice had tumor regrowth after the first TSH and no tumor regrowth after the second TSH. 4 dogs had no regrowth, and 4 dogs had no imaging report available or only one postoperative imaging study was performed. 2 dogs had tumor regrowth based on postoperative follow-up MR imaging. One of the dogs underwent MR imaging at 6 and 9 months post-TSH. This dog developed clinical signs of mass effect at 9 months post-TSH and regrowth was confirmed on imaging performed at that time. The other dog underwent MR imaging 10 months post-TSH after developing clinical signs of mass effect and tumor regrowth was confirmed. This dog underwent a second TSH and following remission, clinical signs of mass effect recurred 2 years later, but then no regrowth was noted on MR imaging. For the 4 dogs with no regrowth reported on MR imaging, 1 developed clinical signs of mass effect. 3 of the 4 dogs where tumor regrowth was unknown developed clinical signs of mass effect. 3.10. Cause of death. 5 dogs died or were euthanized prior to discharge. 2 dogs were euthanized, and 3 dogs died, of which 2 dogs had no documentation regarding cause of death. Euthanasia was elected for 1 dog due to owner's perception of a poor prognosis based on difficult tumor removal and preliminary cytology being consistent with carcinoma. This dog was euthanized prior to recovering from anesthesia. The second dog that was euthanized never recovered from anesthesia and the owners elected euthanasia. In the 3 dogs that died, 1 had documentation of cardiopulmonary arrest with unsuccessful cardiopulmonary resuscitation. Of the 10 dogs that survived to discharge, 6 dogs were later euthanized, 2 dogs died, 1 dog was lost to follow-up, and 1 dog was still alive at the time of rating. 3 dogs were euthanized due to development of progressive neurological signs, 2 dogs were euthanized due to progressive paraparesis and other hind limb changes, and 1 dog was euthanized due to complications recovering from anesthesia post-debridement of a subcutaneous abscess. For the 2 dogs that died, 1 dog had CPA from complications associated with ruptured splenic hemangiosarcoma, and for 1 dog the cause of death was unknown. 4. Discussion. All dogs presented with clinical signs of mass effect and dogs with NFPA that survived to discharge had a good to excellent outcome based on available owner responses. In our study, there was a 33% mortality rate. The results of this study support our hypothesis that dogs with NFSM, specifically NFPA, can undergo TSH and have resolution or improvement of presenting clinical signs. Mentation change was the presenting clinical sign in 12/15 dogs. Although clinical signs in dogs with NFSM have not been reported, Minchetti et al. Reported abnormal mentation and behavior changes as the most common neurological signs in dogs with detectable pituitary masses in humans with NFSM. The most frequently reported symptoms include headaches and visual disturbances, clinical signs of low head carriage, hyperesthesia of the head and neck, and inappropriate reaction to light and hand movements near the face could be indicative of a headache in dogs. Dogs may experience headaches, but this cannot be diagnosed as this symptom has to be verbally communicated. Dogs are less likely than humans to have visual disturbances due to the differences in anatomy and lack of involvement of the optic chiasm. 5 dogs had visual changes, with 1 dog later being diagnosed with retinal blindness. The pituitary adenoma was likely an incidental finding as the tumor did not involve the optic chiasm. There are no standard criteria for the diagnosis of NFSM in veterinary or human medicine. In the human literature, these tumors are diagnosed based on the absence of hormonal hypersecretion on laboratory tests and or lack of clinical manifestations. Gestier et al. Diagnosed an 11-month-old Weimaraner with a nonfunctional pituitary corticotroph adenoma based on lack of clinical manifestations of hypercortisolism. Giger and Nolan differentiated functional and non-functional pituitary tumors based on clinical signs and by performing endocrine testing in dogs with clinical manifestations of hypercortisolism. In our study, 5 dogs were diagnosed with NFSM due to the mass being of non-pituitary origin on histopathology. 9 of 10 dogs were diagnosed with NFPA based on no clinical manifestations of hypercortisolism. 1 of the dogs with an adenoma did have hair loss, which can be a sign of hypercortisolism, but also had weight gain and a low total thyroxine concentration, which was consistent with hypothyroidism. Biochemistry results for this dog were consistent with NFPA. An accepted definition for NFSM needs to be established in veterinary medicine, so accurate comparisons can be made across the veterinary literature. All dogs had an enlarged pituitary gland. The mean PB ratio was 1.05. Dogs with functional pituitary tumors are typically diagnosed earlier in the disease process due to clinical signs of excess production of endogenous cortisol and have smaller PB ratios. This is compared to dogs with non-functional pituitary tumors being diagnosed later in the disease process after the development of clinical signs of mass effect in the brain. This presentation and TIM of diagnosis is similar in humans. Ryan et al. Found that with increasing surgical experience, TSH remains an option for dogs with PTH and large pituitary tumors. Sato et al. Determined that dogs with functional pituitary tumors of type A, grade 1 to 3 had a good prognosis following TSH and that dogs with grade 3B, 4 and May 5th not to be suitable for TSH. Sato et al. Consider these dogs unsuitable because only partial resection could be expected without radical cure. Although this was developed for functional pituitary adenomas, it is an objective way to assess sellar masses. 13 MR images were retrospectively evaluated to classify each tumor. MR images for 2 dogs were unavailable. 13 dogs had a tumor classified as 3B or higher, with 8 out of 13 classified as 5B. Although the intention of surgery is to remove the tumor in its entirety, this is rarely accomplished with larger tumors. 8 of the surviving dogs had known incomplete tumor removal. Of the 7 owners that reported a good to excellent outcome, 6 of the dogs had incomplete tumor removal. Ease of tumor removal in surgery appeared to be dependent on tumor consistency, with soft tumors being easy to remove and firm being more difficult to remove. In human medicine, there is no standard classification system for pituitary tumor consistency, but soft and fibrous are the 2 main consistencies described. Most pituitary tumors in humans are soft, which facilitates removal. Several attempts have been made in human medicine to predict pituitary adenoma consistency preoperatively by analyzing clinical and radiological features. However, the results have been inconsistent. Further studies in veterinary medicine to predict tumor consistency before surgery could allow for better preoperative planning and risk assessment. At the first institution, immediate Postoperative imaging was not performed. This protocol was changed at the second institution, and a postoperative CT scan was performed immediately after surgery. It would be beneficial to measure tumor volume before and after TSH to have an objective measurement for tumor removal. Knowing the tumor volume post-TSH and comparing it to postoperative follow-up imaging would hopefully allow for rapid diagnosis of tumor regrowth. All dogs diagnosed with tumor types other than adenoma or meningioma died. In the immediate postoperative period, it was suspected that tumor consistency and intraoperative hemorrhage may have affected survival, but no significant differences were found. The reason for a 100% mortality rate in the other tumor type group was not identified. Humans and dogs are similar in that most sellar tumors are pituitary adenomas. 11 of 15 dogs were diagnosed with a pituitary adenoma. Although tumor type cannot be determined prior to TSH, most dogs will have a pituitary adenoma, which appears to carry a more favorable prognosis. Superficial corneal ulceration occurred in 3 dogs that recovered from surgery. Dogs that undergo hypophysectomy can develop keratoconjunctivitis due to direct or indirect neuropraxia of the major petrosal nerves. KCS can lead to superficial corneal ulceration if left untreated. KCS was not documented in the 3 dogs. 1 dog had a Schirmer tear test performed postoperatively which showed normal tear production. This dog was a Boston Terrier, which may be prone to corneal ulceration due to exophthalmos, an anatomical variation seen in the breed. The other 2 dogs did not have Schirmer tear test results available. Precautions were taken to reduce the risk of corneal ulceration while under general anesthesia, including excessive eye lubrication and taping the eyelids closed during the procedure. There is no consensus in veterinary medicine for the best treatment modality for large pituitary tumors in humans. The treatment of choice for clinically relevant NFPA is surgical resection. Surgery for NFPA in humans is infrequently curative, with at least 50% of surgically resected tumors having recurrence. Adjunctive RT is typically reserved for more aggressive and recurrent tumor types, although reoperation is usually indicated if the tumor is causing clinical signs. Treatment options for dogs with large pituitary tumors include RT and TSH. Radiotherapy has been used to treat large functional and non-functional pituitary tumors in dogs with reported median survival times ranging from 235 to 961 days, but prognosis appears to be dependent on the protocol. Severity of neurological signs and tumor size. Benefits of TSH over RT include decompression, rapid resolution of clinical signs, and tissue sampling which allows for histopathological diagnosis. Another possible benefit is tumor debulking before RT, as several reports have shown that dogs with smaller pituitary tumors undergoing RT live longer than those with larger tumors. Owners were contacted to determine if surviving dogs had resolution of clinical signs. Only owners of dogs that survived a discharge were contacted. The responses regarding having the surgery performed again could be biased, as all dogs survived. A limitation of the study is that only 7 of 10 owners responded. We do not know the level of satisfaction of the 3 owners that did not respond. There could be bias in the results in that only owners that were satisfied responded. Other limitations of this study include its retrospective nature and small sample size. The development of a prospective study design with clear documentation of pre- and postoperative neurology examination findings would allow for collection of objective data to support our claim that TSH can result in resolution or improvement of pre-TSH clinical signs. Future studies focused on identifying tumor type before surgery may be of benefit because prognosis in this study appeared to be dependent on tumor type. Adjunctive therapy may improve survival when done in conjunction with surgery, although further studies comparing surgery alone versus surgery and adjunctive therapy are needed to confirm this result. Ultimately, planned transsphenoidal debulking within the safe surgical margins followed by adjunctive therapy could be effective in improving quality of life and relieving clinical signs of mass effect. For a large NFPA, life expectancy may be prolonged, despite the increased morbidity and mortality that is inherent to TSH for NFSM.
Just a couple things that I want to go through just to make sure we're on the same page before I start giving some of my thoughts on the article. So remember that when we're getting the pituitary to brain ratio, that it's going to be the area of the brain, not the volume of the brain. So as you can see in this image here, you just get the length of the pituitary, the height of the pituitary tumor, and then you can encircle the area of the brain itself. And hopefully you can see that it's outlined here. And that area of the brain also includes the pituitary tumor itself. And that's how you're able to get the pituitary to brain ratio. At least that's how it's performed historically, and based on the articles that were cited, I'm assuming that's how they did it in this paper as well. The other thing to go through is going to be the different grades and then the different types. So just to go through that, grade 1 is no tumor, or at least no tumor extension beyond the dorsum sella. Grade 2 is the tumor extends beyond the dorsum sella up to the third ventricle, but does not contact the optic chiasm or the mammillary body. For grade 3, the tumor extends beyond the dorsum sella and up to the third ventricle and contacts the optic chiasm or the mammillary body, but not the interthalamic adhesion. Grade 4, the tumor extends beyond the dorsum sella, contacts the optic chiasm, mammillary body, and the interthalamic adhesion. And then grade 5 is the tumor occupies the third ventricle. To further evaluate, as far as the type A and B, it's looking at blood vasculature or blood vessel involvement. And type A is going to be no involvement of the arterial circle, and then type B is going to be involvement of the arterial circle. So grade 1 and 2 tumors can't have involvement of the arterial circle, whereas grade 4s and 5 and sometimes 3s can. I think the introduction does a very nice job, and the objectives outlined in this paper are met. The information about the patients and tumors is invaluable. The original paper describing the grades stated that surgery was not recommended for grades 3 through 5. In this paper, all the tumors were between those grades, with 8 of the 15 being grade 5B. Thus, this is the worst of the worst when it comes to these pituitary tumors, so although having a third of dogs die from surgery seems high, this is a very high-risk group of dogs. That said, in 11 of 15 dogs, known tumor was left behind, and it wasn't stated how much of the tumor was left behind. Looking through Table 1, Dog 2 survived 1,500 days with only surgery performed. Dog 3 had 2 surgeries performed, surviving 1,200 days. Dog 4 and 5 both had radiation therapy, and they survived 410 and 1,700 days. Dog 6 only had surgery and only survived 125 days. Dog 7 had chemotherapy and surgery, surviving 793 days. Dog 8 and 10 survived 624 and 929 days and had radiation therapy and surgery. And the others were less than 230 days with less information provided, but potentially only had surgery alone. So currently it seems that combined surgery with radiation therapy might be best for dogs with pituitary tumors, but based on the numbers provided in this, statistical analysis could not be performed. It is worth going through Figure 1, and I'll just start with saying it would be nice to see the planning CT for radiation therapy and not just the postoperative CT. Based on the postoperative CT and following MRI, I feel radiation did more for this dog than the surgery did, and this is always going to be the debate in these patients, at least right now, is does surgery help with survival compared to radiation therapy alone? And currently we have no idea. Although I will say it is going to be heavily reliant on the surgeon's skill, although most neurosurgeons performing this are going to be highly skilled neurosurgeons. So just like most of our intracranial tumors, there's always the question, does surgery alone, surgery plus radiation therapy, or radiation therapy alone provide the best long-term outcome? One patient in this study did receive 80 gray of radiation therapy, which seems quite high to me, but I'm not a radiology oncologist, so it's hard for me to truly comment on the potential consequence of receiving this much radiation therapy. In the discussion, mentation change was the most common clinical sign, which is something I would agree with, and visual changes are quite uncommon, though not impossible. Pituitary tumor was the most common tumor diagnosed, with only one of these patients having meningioma. And I would say, based on my experience, I would agree it's uncommon to see meningiomas in this area, but we do see it from time to time. There were some minor details that I did disagree with. The only one I'll point out is it seems that although one of the dogs they said did not have a functional pituitary tumor, they only checked total T4 in this dog to say it was hypothyroid, which is not the best way to diagnose hypothyroidism. And this dog could have had Cushing's, and as best as I can tell, there was not a low-dose dexamethasone test performed on this patient or other endocrine testing to rule out Cushing's disease. Overall, though, this was a very informative study, and I quite enjoyed reading it. This is a surgery I would love to learn one day, but until we have a robust critical care service, I'm reluctant to learn this as I don't feel I could manage these patients properly on my own post-operatively. But those are my thoughts. Thank you for listening.